intubation, RSI, if you want to call it that. Most different names, pre-medicated intubation, anything you want to call it. But bottom line, what are we talking about here? We're talking about giving somebody medications to make them relax so that we can facilitate an intubation and manual ventilation. Right? MAI, as described, for facilitation of to relax the patient for facilitation of intubation and to facilitate manual ventilation. Right. Yeah. So we want to talk about intubation a little bit. We want to talk about some of the pharmacology and discuss the procedure and think about the backup plan. Right. So why would you intubate somebody? Obviously, apnea is number one on the list. Why would you intubate somebody?
Protect the airway.
To protect the airway. So, you got a guy who fell and busted his noggin, and he's posturing and he's breathing 8 times a minute. Oh, we don't need to intubate him. He's breathing. Is he? He's what we need to protect his airway. We also need to, help him out to help him with his ventilations when they're not effective. So, I guess the question I'm asking is apnea the only reason you would intubate somebody? And
No.
the answer is very, very plainly no. Right? We're going to protect your airway with it. I suggest, there's a lot of controversy about pre-hospital intubation now, but I suggest, and I put out there that we intubate patients in the field more for airway protection than we do for actual ventilation. Right? We do it to protect the airway because of the circumstances they're in and the things that are going on with them, and to keep them from tossing their stomach contents directly into their lungs, right? And so I think that we do a whole lot of airway protection. We do a lot of ventilation, but we do a whole lot of airway protection, I think. Indications, apnea, airway protection, anytime he's got a decreased LOC, anything like that. What about contraindications? Are there contraindications to intubation? Are there any contraindications to, say, a nasal intubation? Well, when you take his face and move it in a complete circle, we probably don't want to start throwing a tube down his nose. How about, especially a baby, diaphragmatic hernia and a loop of valve up in the chest cavity? You start applying positive pressure to that, then you're going to start strangulating that valve, and that's something to think about too. So we've got advantages, we've got disadvantages. The ability to ventilate a patient that's not able to be ventilated if his teeth are clenched, or he's in a spasm, or he's in he's posturing from a head injury or whatever. Disadvantages, complications, disadvantages. What happens when you don't get it? You try to put the tube in and it's not there. When I first went to Life Force, the chief flight paramedic had all the medics in the room, all the Life Force 2 medics, actually all the medics in there. And he says, boys, it's like this. He said, on scene and in that aircraft, you are the bottom line for airway management in your patient. No ifs, ands, or buts. You are the bottom line. So you can take that here, in the back of that truck, on the scene, wherever you're at, whether it's a hospital, if it's a nursing home, whatever, on scene and in the back of that vehicle, you are the bottom line for airway management, right? It's you. It's nobody else but you, right? Now, if you're working with a paramedic, then it's a shared responsibility, although somebody's got to be driving, right? But when it's just you, when you're the highest level of licensure on the truck, you are the bottom line for airway management in your patient. And if your patient gets managed appropriately, it's because you did it appropriately. We've kind of moved away from the nasal intubation a little bit, but it's still a valid option, right? If you don't have the ability or the equipment or the drugs for RSI, and you can do the nasal intubation, it's still a valid option. We still teach it in school, and it's still a valid option to get your intubation complete, right? Tell me about Selleck's maneuver. What is Selleck's maneuver?
Manipulate the trachea for visualization.
Right. What's our mnemonic for Selleck's maneuver? Burp. Backward, upward, rightward pressure, right? Taking the trachea and displacing it just about maybe an inch to half an inch back and towards the right ear, just to facilitate pushing that semi-rigid trachea against the flaccid esophagus. The American Heart Association in 2015 and their guidelines changed, de-emphasized Selleck's maneuver. They, their feeling is it's not that effective. It is not contraindicated, but it's de-emphasized, right? Those of us in the field tend to use it and tend to use it for the reason that it's there for. It's not, you'll hear, well, it's supposed to help open up the trachea so you can see it. And that's really, that may be a secondary thing you might get out of it. But the primary reason for Selleck's maneuver is to push that semi-rigid trachea against the flaccid esophagus to keep him from throwing up, right? To keep him from throwing emesis into his lungs. And just remember, what's the first thing, one of the first drugs we're giving him? We're giving him Versed or something to drop his LOC. So as soon as you start dropping his LOC, he loses the ability to protect his own airway. So I still use Selleck's maneuver, and until I'm told not to, flat out don't do it. I probably will continue to use it because I think it works, and for what we're doing, I think it works very well. How many ways are there to confirm placement of your endotracheal tube? I can think of 12 right off the top of my head, right? So go around the room, give me one. Can't repeat.
SpO2.
Okay, SpO2 doing what? What should it do?
Oh, it should be.
It should increase. Yeah, it should increase. Okay.
Oh, volume of tube.
In the presence of other signs and symptoms, right? Not valid by itself, but in the presence of everything else, then you could use tube fogging, right? Waveform capnography is the gold standard these days. But of all the things I've seen come down the pipe, and all the new toys I've seen come down the pipe, probably the one with the most impact I've seen to date is a waveform capnography. Because A, it gives you an idea that your tube is in place, but B, it also gives you an idea that you're perfusing. But the biggest thing is it gives you a very good look into one of the two major parameters that cause acid-base balance in your body, right? Remember, end-tidal CO2 and PCO2 are very, very closely related. Usually no more than about 3 millimeters of mercury off, but a lot of times it's 1-to-1. And when I can look at his end-tidal CO2 and get a good idea on his acid-base balance, and therefore get an idea on why he's doing what he's doing or why he's not doing what I want him to do, and that's just it's just an awesome tool. It's probably one of the best tools I've seen come around.
Auscultation of the lungs.
Auscultation of the lungs
and over the epigastrium.
Equal breath sounds and the epigastrium. So we don't want breath sounds here, we don't want breath sounds there, right?
Exactly.
Okay, all right. If we got breath sounds there and not here, we have a problem. All right.
Skin color.
Skin color. He's purple, now he's pink. Bing! Or we're doing something good somewhere.
X-ray.
Chest X-ray. Got one of those in my back pocket, right? So there you go. So as a very good secondary measure, X-ray. If you're going to do an X-ray, what's the best way to do it? You want just a A&P? No, you really want an A&P and a lateral. ABGs. What do you expect to see on your ABGs as a secondary verification of tube placement? You expect to see what?
Return to normal.
What return what to normal?
Well, PO2 to return to normal, like between 80 and 100.
And his PCO2 to do what?
His PCO2 to
Should
come
be
down,
decreasing.
right? And his PO2 to go up. There you go. You might think, well, we want his pH to return to normal. Well, his pH might not return to normal if it's a metabolic issue, right? But we definitely want to make sure that ventilation is all about CO2, right? It's all about getting rid of CO2. Because we can oxygenate on room air. We do it every day of our life. But we want to make sure we get rid of CO2. So ventilation is about CO2. So we want to see, so there you go. Again, so why might we think about medication-assisted intubation? Robert's Rules of Trauma Care. Number 2, every patient that you will attempt an airway maneuver on will just have finished a meal of chili and beer with pickles, corn, and hot dogs during every measure, right? That's trauma care number 2. Robert's Rules of Trauma Care number 1 is what? If it looks bad, cover it up. Right? So, there we go. So you got the full stomach theory. They're going to you know, they're going to have a full stomach. Unlike surgery, you know, they have to be NPO for at least 8 hours, and if they had a cup of coffee this morning, they bump them back. They know you can't go. Well, we don't have that luxury. You know, our patients have just finished a meal of chili and beer with pickles, corn, and hot dogs thrown in for the measure, and we've got to recognize that, and we've got to deal with that and work around it and learn to mitigate that, right? So head trauma, increased intracranial pressure, overdoses. We're seeing a lot of overdoses these days, and it's crazy.
Eastridge has had 9 in the last 3 days.
Heavy duty, the heroin, is it fentanyl laced, or the heroin laced fentanyl, or fentanyl laced, right? Chest trauma, you know, that's an idea. Just be careful, RSIing or MAIing a chest trauma, because what is positive pressure going to do to a small pneumothorax? It's going to make it a big one, right? What's it going to do to a big pneumothorax? It's going to make it a tension pneumothorax. Anytime you put positive pressure on a pneumothorax, you're going to make it worse, right? So just keep that in mind. You know, you gotta do what you gotta do and secure his airway and support his ventilation, but make sure that we keep an extra little listen and look towards his pressure inside his chest, and make sure he doesn't develop a tension pneumo. Using an automatic ventilator, keep your eyes on your high pressure alarm, and when your high pressure alarm is continually going off, that ought to be a reason for you. I mean, the first time it goes off, you need to reassess your patient, right? And it might be a time for you to think, you know, and he starts losing. Again, respiratory failure, upper GI bleeds, esophageal varices, any kind of things like that, right? You know, do we need an urgent versus an emerging airway? Urgent airway means we need to do it now. Emerging airway means we needed to do it 10 minutes ago, right? So there we go. And then, you know, is this an oral nasal intubation we talked about before? Then what about your backups? A combi tube or a King LT?
Surgical crack.
Surgical crack is a backup.
Needle drop.
The iGel.
We got the King LTs.
Yeah, and King LT is it's a good airway. I like it. When we first started using them, I like it.
I like the combi tube too.
All right, so what about difficult airways? You know, you see this guy, and we can all recognize somebody who we think is going to be a difficult airway, right? The most common one, the guy built like a fire plug, right?
No
Thick
neck.
shoulders, big head, no neck, right? Built like a fire plug. We recognize those, okay? But then, you know, there's some others that we have to think about. Mouth, mandible. What happens when he's got multiple mandibular fractures? And so you try to put the blade in and go up, and his entire jaw folds around the laryngoscope, right? Excessive weight, deformity. You know, just what happens when he's got neck deformities or something, some kind of facial deformities or head deformities. You know, the incisors. You know, if she could eat an apple through a picket fence, she's probably going to be a difficult intubation, right? So you got to think about dental appliances and some of these. You know, you got people running out around here that had dental surgery to cosmetic surgery to make themselves look like a cat or vampire teeth or whatever. And, you know, okay. You got to think about C-spine. What if he's a C-spine patient? You know, or thyromental distance is even one of them. The thyromental distance is distance from the thyroid to the chin. Right. If it's not at least 3 of the patient's own fingers, probably going to be a difficult intubation, right? So I've got probably 4 there. But the uvula, you know, hanging down thing in the back, right? If he's got, and that's there to tell you big time gag reflex and things like that. Burns, obviously, if he's burned pretty good, you may have difficult airway. When he's throwing up lunch, throwing up breakfast lunch, throwing up everything for the last 24 hours, right? It's kind of hard to stem that sometimes, so you may have to go to an alternate type, for example, a digital, right? And then stridor. I mean, what we know of stridor, upper airway, high-pitched crowing sound, upper airway obstruction. So, you know, what happens when his trachea is swollen to the point you won't even accept a tube, right? What about children? We always hear that kids are more superior and anterior, okay? But what does that mean? Well, the adult laryngeal structure hangs out about the level of C4, C5. Okay, that's about that level. Pediatrics hang out about the level of C3, C4 up until the age of about 7 or 8. They're really, they are a whole vertebral interspace higher, and as such, they're more anteriorly placed. So, you know, with an adult, you may have to go in there and, you know, kind of look. With a child, usually you get that big floppy tongue out of the way and get that epiglottis out of the way. The epiglottis typically is bigger and it's more angled and can be more floppy. You get those out of the way, and that set of chords should be right there, right? We know that the adult airway is cylindrical from the top, from the oropharynx down to the laryngeal structure. The pediatric airway is funnel shaped, right? And the narrowest portion is the cricoid ring, right? So what's the cricoid cartilage, the cricoid ring? What's its claim to fame? It's got 2 claims of fame.
Complete cartilaginous ring.
All right, it's the only, first off, it's tracheal ring number 1, right?
Mm-hmm.
And it's the only true 360-degree ring, right? All the other tracheal rings are what? They're C-shaped, right? With the opening towards the posterior. But the cricoid ring is the only true 360-degree ring. So, you know, always always previously, what did we do? We would try to get the right size tube to go in there that would seal that ring. Okay. Now what can we do? We have that option, but we can do something else. We can use an uncuffed tube, right? Because before we were using an uncuffed tube to get the right size. Now we can use a cuffed tube. Drop your tube size down about half, or about one size, you know, half size. So if you're going to use a 5, use a 4.5 cuffed, and you can pop it in there and then seal that. Remember, you don't get true positive pressure ventilation unless you have a sealed system, right? If you got a leak, you're not going to get positive pressure ventilation. So if we can use a cuff tube down a pediatric patient, that'll work fine too. Some things to remember: you've got to have confidence in your airway skills before you start this, okay? And confidence is not arrogance, right?
No, it's not.
Right? So you can be confident without being arrogant, right? Confidence to me is, you know, I've got the training and the skills and the experience that I know that if I'm going into an intubation setting, that I feel like at least 95% of the time, I'm going to get the job done. There's going to be those 1 or 2 outliers that nobody would ever get. But based on my training, based on my experience, that I feel comfortable in doing an MAI and making sure that you know, probably 95% of the time I'm gonna get the job done, right? Arrogance is what? Ain't nobody I can't intubate. You ever heard that?
Yeah.
Mm-hmm.
So, but remember, we're taking a breathing patient and we're making them apneic. We're taking away the most basic instinct in the world, which is to take a breath, and we're taking that away. So if we're unsure of ourselves that we can't get this, then how about let's not give them the drugs in the first place, right?
Right.
Because you're gonna cause more problems than you're gonna fix, right? So we use MAI because it helps us out. We can use it for a wide variety of airway emergencies. It's more humane than an awake intubation. You know, what happens if we're unable to ventilate him or unable to intubate him? What happens if he's got some deformity or some pathophysiology like that? You know, well, maybe we have to try to go around it. Maybe we have to try to do something else. Maybe we might have to even take the step of going transcutaneously, right, and do a surgical airway. Well, what happens when we're unable or untrained to provide a surgical airway? Then we have another problem, right? So, simple thing about it. All right. So the procedures then, as we go through the procedure, just remember the 6 P's, right? Preparation, pre-oxygenation, pre-medication, paralysis or relaxation, pass the tube, confirm, secure it, and then prepare for transport. So the 6 P's will get you where you go. Okay. Preparation is probably the most critical stage of this whole thing. If we don't have everything prepared, then, you know, we're asking for trouble, right? You know, if we in the middle of having, in the middle of an intubation, and you're just entering the mouth, and your laryngoscope light goes out because your batteries are dead, it's not the time to figure that out, right?
No.
It's not the time to figure it out that, when you got an apneic puking patient, that is not the time to figure out that your suction has a crack underneath the lid to the canister and it won't pull a vacuum, right? That's not the time to figure that out. All this stuff should be figured out when? In your morning checkoff. In your morning checkoff. And you making sure that everything is there, and making sure that it's where it needs to be and it's working. All right, stage with the most error. Obviously, you gotta have an IV line. Obviously, you gotta have cardiac monitor, pulse oximetry, and I keep forgetting to put waveform capnography on there too. But waveform capnography goes there, making sure the equipment works. If you've got extra people in there with you, people that aren't used to this, making sure they understand what's going on. I'm fixing to give him some drugs. He's gonna stop breathing. We're gonna breathe for him, and we're gonna take care of his airway. Rather than, we give the drugs and then somebody's going, well, he's not breathing, oh, well, we know that. This is what we want. So let them know up front. For example, if you've got firefighters or somebody else that's not in tune with what we're doing or not trained to understand what you're doing, then making sure that they understand it so they won't freak out. All right. We want to pre-oxygenate him. We probably need to take the non-rebreather out if he's breathing and put in what? Nasal cannula, right? If he's inadequate, we can ventilate him with a bag mask and an oral airway or a nasal airway. If he can take an oral airway, he can probably take a laryngoscope, which means you may not have to go through this procedure, right? But something to think about. Just be aware that anytime you ventilate the patient, you're going to blow air in his belly. Right? The best positioning you got, if you don't have an intratracheal tube, if you're using a bag mask, you're going to blow air in his belly. Remember, the intubation can cause an increase or decrease in your pulse rate. If you stimulate the vagus response, then it's going to drop your heart rate, it's going to drop your blood pressure. If you stimulate a sympathetic response, if you didn't get the vagus nerve and he's fighting you, then he's going to kick his heart rate up, it's going to keep his blood pressure up. His ICP is going to spike probably, and his interocular pressure is going to spike probably. So some things to think about. Some of the medications that we use, for example, lidocaine is thought to can help blunt the ICP spike in the RSI procedure. I've seen about 8 different studies from the mid 80s all the way up to 2000, 2005, I can't remember. But I've seen 8 studies about lidocaine lowering the ICP in an intubation attempt. 4 of them said, yes, it does, go ahead and use it. 4 of them said, no, it doesn't, don't need to use it. Right? Lidocaine is I don't see it used that much anymore in most RSIs. It was initially when we started doing RSI, it was a have to. I don't see it that much anymore. It may still be in your protocols. It may still be in protocols that you come across. If it is in the protocol, it might say consider it, right? But whether you use it or not, or whether it's actually in protocol here, I think here it's not. So remember, the intubation can cause bradycardia in some pediatric patients. In the AHA, the American Pediatric Society, de-recommended the using atropine as a pre-med for pediatric intubation, right? We used to do that all the time. That was a have to. Yeah. And when the 15 guidelines came around, that was taken out. So they said it doesn't really work. Well, okay, whatever. Unless the patient is already bradycardic. If he's already bradycardic, especially in the adult, if he's already bradycardic, probably not going to hurt him. Right? You can touch him with a 0.5 milligram and see when he can get his heart rate up a little bit. Right? But we could use lidocaine if it's in your protocols. We can do that to reduce ICP. But like we said, most of the time it's no longer there. Atropine, if he's obviously bradycardic, to help reduce his secretions and to blunt his vagus. What is atropine? Well, it's one of our cardiac drugs, really. Would you think I was crazy if I said atropine, one of your primary cardiac drugs in your drug box, has no direct effect on the heart?
I believe you.
What? It's one of our primary cardiac medications. Yeah, but it has no direct effect on the heart.
Heart.
How does atropine work?
It's on the nerve.
Atropine depresses the vagus response. Well, what does that mean? Well, atropine is anticholinergic, right? It's muscarinic anticholinergic. It means it works against or inhibits the production and release of muscarinic acetylcholine, right? Remember, you got two types of acetylcholine. Muscarinic, that's in the smooth muscle and cardiac muscle. Nicotinic, that's in the skeletal muscle and the diaphragm, right? And so, atropine is a muscarinic anticholinergic. It inhibits muscarinic acetylcholine's production and release, right? So muscarinic acetylcholine is what runs the vagus nerve, right? It's the chief transmitter in the parasympathetic nervous system. It runs the vagus nerve, and so it's going to decrease vagus impulse, but also and part of that vagus impulse too or part of that muscarinic acetylcholine is making excess mucus, and so it's going to make you, atropine is going to dry you up, which is why they're giving it to you in surgery or pre-op, because the anesthesiologist or anesthetist wants a nice, clean, dry airway. He don't want a big, spoogey, wet airway that he has to deal with. So he's cleaning you up and drying you up with this atropine. The effect on the heart rate, you give atropine, the heart rate goes up. That's a side effect because you're removing the brake, which is muscarinic acetylcholine that runs the vagus nerve. That's the brake that slows the heart rate down. Take away the brake, what happens to the motor? Runs up. Okay. So your atropine's effect on the heart is a side effect. It's not a direct effect. Right? That's probably the most common thing we use. We could use morphine. We could use fentanyl, right? Which benzos and narcotics are the ones we tend to use the most. But most of the time, we're going to use a benzo. Most of the time, we're going to use which one? Versed, right? Versed. Can we use Valium?
Yeah.
Why do we use sedatives?
Because it's fun.
I mean, bottom line, why do we use a sedative in this? We're going to use Norcuron, or maybe we'll use succinylcholine. We're going to give him a paralytic. Why do we use a sedative?
Amnesia.
Who in the world would want to be awake for such a procedure?
Right, but we're taking him down with the paralytic, are we not? Why do we have to have sedative?
Humane.
I'm talking about
Ah.
psychological.
He's not going to be asleep. He's giving us what's going on.
The neuromuscular blocking agents, succinylcholine, Norcuron, rocuronium, all of those, they work on what? They work on skeletal muscle and the diaphragm. They have no effect on the CNS, right? So you've got to be humane. You've got to sedate him in order to get this procedure. If you don't, that's just cruel and unusual punishment. But yeah, the neuromuscular blocking agents have no effect on the CNS, so we have to sedate him. The only time you probably won't give a sedative prior to this procedure, if your patient's already unconscious and he's already hypotensive to the point that any sedative that you give him short of fentanyl is probably going to drop his blood pressure even further. So we hope we'll make it worse. But most of the time, 99% of the time, we're going to use a benzo or a narcotic to try to drop his LOC a little bit, right? Midazolam, probably the most common Versed. How do they work? How does a benzo work? Well, it drops his LOC. Yeah, I know how. Well, it just does. I know how. How? In the grand scheme of all your brain cells, right? Your brain cells, they depolarize and repolarize just like heart cells and just like every other cell, right? And so when you're depolarizing, you're putting out electrical energy. When you're repolarizing, you're getting everything restarted, right? So what happens is during the repolarization stage, basically these benzos lock open the chloride channels, right? So you got sodium channels, you got potassium channels, you got calcium, magnesium channels, you got phosphate channels, you got chloride channels, all this. The benzos lock the chloride channels open, right? So now you can't have chloride moving with sodium, right? Because it likes to go with sodium, but the basic law of physics is in the movement of particles, diffusion, and so all your chloride is not going to be over here with your sodium inside the cell or outside the cell or all that. We lock open the chloride channels so that there are equal amounts of chloride on either side of the cell wall, right? When that happens, you can't depolarize and repolarize the cell. You can't repolarize it because all the chloride is not moving out with the sodium like it should be, right? So you equalize the amounts of chloride on each side of the cell wall, and then the cell will no longer depolarize. It won't repolarize, so it can't go to the next depolarization. So basically, you shut down electrical activity. I mean, the benzos are primarily used for what? Primarily used for seizures, right? Seizure, you got roughly 300 times the electrical impulses going off in your head than you normally do. Your cerebral oxygen requirement is up by about 300%, right? And so what we do, we lock open all those chloride channels, and suddenly all this depolarization and repolarization stops. What happens to the seizure? Goes away, right? So there we go. So what we're doing is we're locking these open, leading to hyperpolarization, decreased neuronal response, right? That sounds like a test answer, doesn't it? So that decreased excitability helps relax the muscles, helps inhibit seizures, and for us, it's going to help drop his LOC, it's going to help relax him, and going to help us facilitate this intubation. Okay? So midazolam or Versed, the other thing it does, it has this nice little about a 15-minute retrograde amnesic effect, amnestic effect. And so from about the previous 15 minutes of getting him, he's not gonna remember what's going on, which works well for us too, right? So 0.01, 0.02 to 0.05 milligrams per kilogram. On the average dose is about 2.5, right? Up to about 5, 7.5, depends on your protocol. I've seen some that say you can go to 10 with it, but about 2.5 at a time, really. When we first started doing some of the RSI, we would say we would give him 1 milligram a minute until he got stupid enough to do it, right? Until we give him 1 milligram a minute of Versed until he was out, and then that was good. But you're going to get profound sedation in 1 to 2 minutes, and it's going to last about 20 minutes, right? Keep that 20 minutes in your head, because that's going to be important here in a little bit, right? So it can cause some hypotension, maybe cause some bradycardia, probably not going to cause an increasing ICP. It can be reversed with flumazenil, but when's the last time you saw flumazenil? What is flumazenil? Romazicon, right? And it was a benzo reversal agent. They ended up having more problems than the benzo did, right?
Yeah.
You'd overdose on the benzo and then give them Romazicon, and if they had anything else in their system, but especially tricyclic antidepressants, they would start seizing, and then you couldn't control the seizure because your benzo receptors were bound up.
Everybody in the world is on now.
Yeah, very much. So there's Versed. That's 5 milligrams in that vial, right?
Not necessarily.
No, not necessarily.
Oh, 5
That's what I said. It's a big old 5 there. It's 5 milligrams in that
It's a 10
vial.
milligrams.
Per amount.
Also, be careful.
5
You and I both know
milligrams,
people that would say, "Oh, that's 5 milligrams. Let's give them the whole vial."
Why did they put the green over the 5 milligrams /ml and make that more prevalent, like a
I
big
don't know.
red?
Yep, you think. So, lorazepam or Ativan is
Good drug.
a good drug, very good drug. It's probably the benzo of choice for pediatrics. They deal with Ativan probably better than any of the benzos. Valium is, it's kind of, if you ever looked at it, it's kind of that pale yellow, and it's very thick. Basically it's oil based, right?
Yeah,
And it breaks down in the liver in kids into several not so nice compounds. And adults handle it okay, but kids don't handle it as well. Probably Ativan is the benzo of choice for pediatrics, and they respond better to Ativan. You could use that. Just remember, morphine has a moderate histamine effect. Most of the narcotics have some type of histamine effect. Demerol has a pretty pronounced one. Morphine has a moderate one, which, with a chest pain patient we may use to our advantage. Here, if this guy, especially if he's depending upon his sympathetic nervous system, right? And so he's in shock and he's depending on his sympathetic nervous system, morphine is going to help with his pain. It's going to help with his LOC, but it may work against his stimulation of his sympathetic nervous system. So something to think about. Right? But and we're dealing with the pain, but we're also dealing with vasodilatation and help to feed his heart a little better with and some coronary artery vasodilatation and systemic vasodilatation. The fentanyl doesn't have that. Fentanyl has the pain relief, but because it doesn't have as much or if any of the histamine response, then we're not getting the vasodilatation with the cardiac patient. Really, not a whole lot of vasodilatation with fentanyl, which is why it's such a good drug for burns, right? Because you don't have to worry about messing with his hemodynamics. You got a lot of good pain relief, but you don't mess with his hemodynamics. Works in seconds, lasts about 5 minutes, right? So you give it to them and they'll go out. They're somewhere. We don't know where they're at. They're somewhere. They're just not with us, and they don't know what they're dissociated from what's going on here.
Looks like a disassociative anesthetic.
Yeah. It kind of is like ketamine a little bit, but it takes them into La La Land. We don't use it kids under 10. We don't see any significant respiratory or cardiovascular problems with it. Now, the thing is, it's funny to say, but if you slam etomidate on somebody, if you rapid push etomidate, it may cause a transient respiratory arrest, but it will not cause respiratory depression. What? If you slam it on them, it may stop their ventilation for 10 to 15 seconds, right? But it's not, and then they'll kick back in and they'll start breathing on their own. It will not take away, it will not depress their respiration and take their ventilations from 20 to 6. It's not going to do that for several minutes. It may, and it's not even a concrete, it may transiently stop their ventilation for 10 or 15 seconds, but that's it, right? But that's if you slam it. If you get it like you're supposed to, then it's probably not going to have any issue, right? But etomidate works very well. It will reduce plasma cortisol levels. It's not really a major concern. Remember, cortisol is what? Cortisol, we call it the stress hormone, right? Whereas dopamine is naturally produced and is a precursor of norepinephrine, chemical precursor of norepinephrine. Cortisol is a chemical precursor of epinephrine, right? And so if we give something that decreases his cortisol production, then that means that if he's depending upon his sympathetic nervous system, if he's in shock and he's depending on his sympathetic nervous system to run his heart rate faster and to vasoconstrict and all those things that the sympathetic system does, then 2 to 3 hours after we give etomidate, he may have a problem with that because he can't maintain that epinephrine production because of cortisol. Right? Hey, we intubated him with etomidate, so they'll know 2 to 3 hours later if he starts having a problem maintaining the sympathetic nervous system, they may need to add a catecholamine like dopamine or Levophed or something like that, so that they can do that. The Vanderbilt, Erlanger, Vanderbilt especially was really big on etomidate for a while, and then because of the serum cortisol levels, they really started backing off etomidate. And now they really don't they won't even talk about etomidate other than say don't use it, right? Erlanger's still using it a little bit, but they backed off of it in the shock patients. And so etomidate is either packaged in vials or it's packaged as a pre-fill. I know that when we took on when I was at Grandview several years ago, and we took on the MAI procedure, and our medical director, Dr. Souter, didn't like succinylcholine. She said, we'll do this, but we're not going to use sucks. Okay, all right. She said, what can we use? I said, well, we've got etomidate. We can give etomidate. Okay, let's do that. And so we did it. We did it very successfully. But when we were putting the drugs on the truck, or we're ordering the drugs to get them on the truck, we looked at the tech was saying, okay, we can get etomidate in either the vial or we can get it in the pre-filled syringe. And I said, I would rather have it in the pre-filled syringe. Okay, let's look at the difference. So the vial was about $3. Okay, the pre-filled syringe with the same amount of drug in it, the same 40 milligrams, was $18.95.
Oh, wow.
So you were $15.95 of it was pure packaging, right?
Right.
So that you're getting the same amount of drug in either one. So
Different pack.
if you give it too fast, it can cause some respiratory depression. It may cause not hypotension but hypertension. 10 to 50% of the cases out there, but a fairly wide margin of safety. The only thing about ketamine really that you got to think about, and especially in kids, some adults will do it, but we see it mostly in kids, is that emergence reaction. The emergence reaction is as they're coming out from under it, as they're metabolizing it out. A lot of times it will cause some pretty vivid hallucinations and pretty vivid nightmares, and so you see some children coming out from under it screaming, right? Now, if you're using this in conjunction with Versed, not an issue, right? But if you're using ketamine alone, a lot of times they'll have an emergence reaction coming out from under it, right? Which is scary, but it's not really hemodynamic or a cardiovascular issue with it. Okay, so you use, ketamine typically in a vial, 500 milligrams in 10 milliliters. There's a 50 over there. So just make sure you know what you're giving, right? Always make sure you know what you're giving. Don't give him that 50 of Versed and 2,500 of fentanyl and 500 of ketamine. You see the summary there gives you a good idea of your drug dosages and your durations and things like that, right?
Yes, nice.
Notice accommodating ketamine, both of them are very short acting, right? Which is a good thing. They're just a whole lot like sucks is get the job done, get in and out, and be done with it. Both of those are very short acting, and then your benzos and your narcotics have a lot more duration. Okay. Our whole purpose here is to do what? Why are we having this discussion in the first place? What's our whole purpose? We need to help him relax so that we can intubate him and facilitate mechanical ventilation on this guy, right? And that's all we're doing. We go through this whole procedure for one thing, to relax the guy long enough to get him intubated and to ventilate him, okay? So with our neuromuscular blocking agents, there's basically two types. There's depolarizing and non-depolarizing agents. There's only one depolarizing agent in use, especially in the United States, but I'm not sure it's not anywhere in the world. There's only one depolarizing agent in use in the United States today. What is it? Succinylcholine. Then non-depolarizings, you see norcuron and rocuronium and tracerium and all these other non-depolarizing neuromuscular blockers. Okay. So we're talking in the skeletal muscle and the diaphragm, right? So you've got your nerve axon coming off the central nervous system, and then it's running down through here, and at where it meets the motor, the muscle group, the specific muscle group that it innervates, right? You got the end of the nerve axon. It's got all these little nicotinic acetylcholine receptors on it. Remember, muscarinic acetylcholine that atropine deals with is smooth muscle and cardiac muscle, right? And skeletal muscle and the diaphragm are nicotinic acetylcholine, made from naturally produced nicotine, right? How many of you still smoke? Anyway, you ever really needed a cigarette and you take a couple big draws off a cigarette, and a few minutes later, you ever notice your hands tremble a little bit? Or if you hadn't had a cigarette in a while and then you get one and your hands tremble a little bit, nicotinic acetylcholine, right? You're putting more nicotine in the body, and so it's being converted to nicotinic acetylcholine, and so it's causing some muscle tremors, right? So the end of the nerve axon down there with all the acetylcholine vesicles. Remember, there are also norcuron vesicles in there too, but the acetylcholine vesicles. And then there's, on the other side of this little synapse, or the other side of this little space, there is the motor end plate of the muscle, right? And so the motor end plate of the muscle, the postsynaptic area, right? Anything before the synapse, before the little cleft, is called presynaptic. Anything on the muscle side of it is called postsynaptic, right? So on the postsynaptic motor end plate, we see all these little acetylcholine receptors, right? And this is just a 2D drawing, but remember this is all a 3D system. We got all these little acetylcholine receptors, okay? And these acetylcholine receptors then are what pick up the acetylcholine that comes down through there. As we send an impulse down the nerve axon, right, it hits the end of the nerve axon and stimulates its acetylcholine vesicles, and they shoot acetylcholine across the synapse. And as they shoot it across the synapse, it binds the acetylcholine receptor, right? That when it binds like acetylcholine to the receptor, it creates a chemical reaction that creates an electrical impulse. That electrical impulse then stimulates that muscle, that particular muscle group, to contract, right? What's the only thing, the sole purpose in life for a muscle? To contract. That's all it does. It contracts. That's its whole job, right? So the nicotinic acetylcholine, as it hits that receptor, creates that chemical reaction, which creates that electrical impulse, which causes that motor end or that muscle group, that specific muscle group, to contract. Okay. As we do that all through our body, right, and then we basically teach our body as we grow up the things we want our muscles to do, and therefore the things we want done, then a very simple maneuver like this, when you think about it, becomes very, very, very complex, right? Just the processes that you have to do to put acetylcholine in, get the job done, take acetylcholinesterase, clean that acetylcholine off so you can shoot more onto it, right? And just the acetylcholine then allows those nerve impulses to cross the junction. And now the neuromuscular blockers, what do? They bind up the acetylcholine receptors, right? That's all they do. It impedes the action of acetylcholine. Now you notice the motor end plate is convoluted.
Mm-hmm.
Why is it convoluted? Why is it not just there? Why is it not like a socket in a ball and socket joint that's nice and smooth? Why is it convoluted? Amyotrophic lateral sclerosis, right? Lou Gehrig's disease. Mm-hmm. Myasthenia gravis, and to an extent Guillain-Barré syndrome, all neuromuscular, degenerative neuromuscular disorders. They have different pathologies, but one thing is common to all three is that the motor end plates straighten. They flatten, right? And when they start flattening, they start losing acetylcholine receptors, and therefore they start losing muscle tone and the ability to control muscles and the ability to depolarize muscles and make them contract and things like that. Because one of the things that all three do is they flatten the motor end plates, and you start losing acetylcholine receptors. And I thought that was interesting when I figured that out. I went, it makes sense. It makes sense. So, okay. So you can see basically it's just another diagram of how of how it looks. But remember that the synapse, I mean, we're talking cellular type spaces here, right? We're not talking this 2 or 3 inches on the screen. We're talking about microns of space, right? Millionths of a meter. So when we give him this neuromuscular blocker, then it's going to start in the face and the neck and then work its way down. Finally, the last thing will happen is the diaphragm. So when he starts to come out from under this, what's one of the first things you're going to see? Belly breathing, right? Yeah. He's going to start seeing diaphragmatic breathing, and then we may see some non-purposeful movement, right? Danger Will Robinson movement. But you're going to see that as he's coming out, you're going to see that abdominal breathing or that belly breathing. Okay. Now, the depolarizing agent, the only depolarizing agent used in the United States right now is succinylcholine, right? So it substitutes for that nicotinic acetylcholine, binds to receptor sites. Succinylcholine chemically is nothing more than 2 acetylcholine molecules bound together. That's all it is, right? So in doing so, we bind these 2 acetylcholine molecules together. They attach to the receptor, And so it's going to do the same thing that acetylcholine does, right? It's going to do the very same thing. It's going to cause this chemical reaction that causes the creation of this electrical impulse that causes that particular muscle group to contract, okay? So when you got multiple muscle groups contracting at different times in different ways, we call that what, Deb? You just said it. Fasciculations, right? Fasciculations, muscle tremors, right? Now, some of these muscle tremors have been documented to be strong enough to break fingers and toes, right? And some of them you're just kind of trembling. In most protocols, we saw early on a defasciculating dose of the neuromuscular blocker. So a defasciculating dose of the non-depolarizing neuromuscular blocker, which was usually Norcuron. So we give about 1/10 of the dose of Norcuron before we gave Sux. We don't even really see that much anymore. Most protocols don't even have a defasciculating dose in there. And you know, I think we did it early on because we were so conscious about not messing this up, right? And so everybody was putting defasciculating dose in, but I don't think we do it as much anymore now. But the succinylcholine then is nothing more than two acetylcholine molecules bound together. Now, the acetylcholinesterase, that's normally the chemical broom that cleans that acetylcholine off, doesn't metabolize or clean off the succinylcholine, right? So we have to go to our backup method, which is pseudocholinesterase, right? And pseudocholinesterase then is it's the chemical broom that will clean off succinylcholine, but we have to manufacture pseudocholinesterase. We typically don't have it in enough stores to clean off a good dose of succinylcholine, so we have to work on manufacturing it pretty quick. How long does it take to manufacture it enough to get enough in to metabolize succinylcholine? About 5 to 10 minutes, right? What's your duration of action of succinylcholine? 5 to 10 minutes. So there we go, okay? Sux works, it's semi-ideal, works quick, short duration, but it's got some pretty significant side effects. It does completely take away their respiratory drive, so that's a thing to think about. And you know, it's got some fairly significant contraindications too. It may precipitate hyperkalemia, right? Think about this: when you give Sux, and you're causing this depolarization, this one big depolarization all over the body of the skeletal muscle and the diaphragm, every time you're depolarizing, you're squirting potassium out of the cells, right? And so as this continues, then you're putting excess amounts of potassium in the bloodstream, and basically it can cause hyperkalemia, cause a little bit of serum hyperkalemia, right? There are a couple of documented cases of that serum hyperkalemia being enough to cause cardiac arrest, right? So it's not common, it's fairly rare, but it's a potential. It's there. It's one of the things you have to think about, right? In somebody with pre-existing hyperkalemia, and you give him Sux, then that could accelerate this cardiac arrest issue, right? So burns after 6 to 8 hours, crush injuries after 6 to 8 hours, sepsis, muscular dystrophy, Parkinson's, Guillain-Barré syndrome, any of those things that would have an intrinsic or an inherent hyperkalemia that goes with them, we may have to think about Sux, you know, before we use it, things like that. You know, with burns and crush injuries, Sux after 6 to 8 hours is probably not a good idea, especially in burns. You can use Sux in burns as long as he's less than 6 hours, right? But you know, if you've got something else that you can use that works just as well, you know, then you stay away from the potential complications anyway, okay? Anybody with a pre-existing hyperkalemia, like somebody who's septic, the muscular dystrophy, the Parkinson's, Guillain-Barré tend to have an increased serum potassium, but you may want to think about those. Who else do we see a lot of that walk around every day of their life acidotic and hyperkalemia? Dialysis patients, there you go. So you might want to be careful if you're thinking about RSIing a dialysis patient. You might want to be careful thinking about using Sux, right? Because they're hyperkalemic every day of their life. Right? So also somebody with a pseudocholinesterase deficiency, It means it's not going to metabolize the sucks, so it's going to hang around longer. Usually, that's not a big deal because we've used it non-depolarizing after we get him intubated, right? So, but we may see prolonged paralysis also in the procainamide usage, or if he's on quinidine or magnesium or lithium. And then those fasciculations, it can be an issue. Most of the time, we're not giving a defasciculating dose of norcuron now, but it's a potential. If he survives it, and if he wakes up, right, he's probably going to have a muscle soreness like he's never had in his life, okay? Depending on what his problem is the reason he got this in the first place, muscle soreness may be the least of his problems, right? But either way, he's probably going to be sore. I guess one of the rarest, but at the same time, one of the most significant complications is malignant hypothermia with succinyl choline. Right? With a malignant hypothermia is a problem. It's a genetic disorder, right? That can be caused by any number of triggers. It's probably got 50, 60 triggers, things that we know that will trigger malignant hypothermia. One of those things is definitely depolarizing neuromuscular blockers, which sucks is the only one, right? So succinyl choline. You know, dantrolene sodium is the treatment. Dantrium, let's just carry dantrium. Every hospital that performs surgery is required by the FDA to have dantrolene sodium in their ORs or in their most of them call it a hypothermia box or a cart. If it's not in the OR or in the central OR area, it's required to be in the pharmacy, right? But every hospital that performs surgery is required to have this because of potential for malignant hypothermia using succinyl choline. All dantrolene is a muscle relaxer. All it is a muscle relaxer, right? Because when malignant hypothermia, basically you think, well, it's got something to do with the temperature. Yeah, but it basically, you know, the thing that makes you kind of look at this is it causes a sustained systemic muscle contraction in a patient that you've paralyzed, right? And so you're thinking, hey, he's paralyzed, but we can't move his hands. He's clenching down on the tube because he's biting, because his masseter muscle's in spasm. And, you know, what's up with this? Well, dantrolene is nothing but a muscle relaxer. That's all it does. 0.1 on VEC, 1.0 on rock, and then if you're going to use sucks, 1 to 1.5. I like the idea of what you're doing, what we're doing here, and going with ketamine. And then if you get etomidate as a backup, then you know then that seems to be the way to go. And that way, if you're not using succinyl choline, you're not taking away the respiratory drive, so you give yourself a safety pad if you can't get him intubated. And B, you're staying away from all those complications and potential hazards that sucks have. You know, ketamine's been around for a long time. Ketamine was originally designed as a horse tranquilizer, right? And we saw it in Vietnam as Special K, and it was the troops figured out that, hey, you know, woo, we can get happy on ketamine. Ketamine wasn't even a scheduled drug until about 10 to 15 years ago. And when they recognized that people were breaking into veterinary offices and stealing it because it wasn't scheduled, so it didn't have to be locked up. So they were breaking into vet offices and stealing ketamine. And then the FDA is like, we had too many reports of this. We're going to schedule this drug. So it's scheduled now, just like Valium, right? Valium, Versed, all those. It's a Schedule 2, I guess. Yeah. Schedule 2. So it has to be locked up and tracked in the whole 9 yards, just like that. But you know, you get that dissociative anesthesia is a very good thing, right? Because they don't know what you're doing to them, and then you have very few cardiovascular effects, and so you don't have bradycardias, you don't have hypotension, and then you've completely gotten away from, you know, malignant hypothermia and hyperkalemia and all these other things that sucks.
That's why it worked real good in the sandbox. Mm-hmm. So that's the reason why it worked real well in the sandbox when the military went to it.
Yeah.
I mean, they loaded us down with it.
Yeah, exactly. Right, and so NMDAs, neuromuscular blocking agents, caution in patients with myasthenia gravis. Remember we said myasthenia gravis is a degenerative neuromuscular disorder. Paralysis in myasthenia gravis starts centrally and moves peripherally, right?
Right.
So as you start to paralyze the respiratory muscles, and then the next thing you know, you give him a paralytic, he may not have enough muscle oomph to come off the ventilator and breathe on his own again, right? So that's the reason we say in that we use it with caution. Remember, in ALS, amyotrophic lateral sclerosis, his paralysis starts typically in the face and the mouth and the airway, and then moves central and then moves peripheral. Myasthenia gravis starts centrally and moves peripherally. Guillain-Barré, or that that Guillain-Barré, right? Not Guillain-Barré, Guillain-Barré. It's in darn French, right? Guillain-Barré starts peripherally and works centrally. And typically, Guillain-Barré is going to onset. It's transient. It'll onset and then it'll go away. Then it'll onset, then it'll go away. And onset. And it'll do that for years until the time that it finally onsets and doesn't go away, right? And by that time, you're starting to see the peripheral neuropathies that are spreading centrally then with that. But especially with myasthenia gravis, because it's dealing with his respiratory muscles, his chest muscles, then you have to be careful with that, right? Okay. And then prolonged paralysis in those folks, renal failures and drug interactions. That's okay. All right. So immobility, you got to think about DVTs and skin breakdown and decubiti, and corneal abrasions too. Because remember, be nice to the patient. His default position of his eyes is what? If his eyelids is open, right? Mm-hmm. So once you get his airway all squared away and get everything done, be nice to him. Drop some saline in his eyes and tape his eyes shut. Be nice to him so his corneas don't dry out and he doesn't end up getting corneal abrasions. Because if you ever had a corneal abrasion, they hurt. They hurt. They're aggravating. They hurt. Okay. So finally, we get down after all this time to pass the tube. Okay. So when do you know he's timed? When do you know he's ready? When he doesn't have a gag reflex, try blink response. See if you rub his eyelashes and see if he blinks. If he blinks, if he has a blink reflex, he's probably got a gag reflex. That's not 100%, but more often than not. What happens if you're not using sucks, if you're using ketamine? Well, you could do that, right? You could do the blink response too. Also, you can open his mouth. If you start introducing the blade and he takes it without gagging or without biting, he's good to go. I wouldn't use your finger, right? You'll do that once, right?
Yeah,
but you could try that too. We want to limit our attempts to standard protocols. Some protocols will even tell you that you have to have 2 qualified people on scene. You have to have 2 paramedics or 2 qualified people to do this procedure on scene. That kind of limits me, right? Because what happens when, like Warren County, we've got 5 trucks on the road, everybody's got 2 of them out of town and everybody else is on the road and you're up on top of the mountain, right? And got somebody who's burned or that needs the MAI procedure and you don't have anybody else. Does that mean I'm limited? I can't use this protocol because I don't have anybody else. If it's written that way, that's what it means, right? So, it's nice to have another clinician ready with equal skills. That's not always possible, right? So it's nice to have another clinician ready, but a lot of times it's just you, right? And so what's that? That goes back to that statement we said earlier. On scene, in the truck, you are the bottom line for airway management of your patient. And if it's going to get done appropriately, it's going to be because you did it appropriately, right?
Right.
So there we go. So confirm the 2 positions, like we said, secure it, reconfirm it, just like we always do, okay? We're going to prepare for transport, continued sedation and paralysis, and then again, every 20 minutes, he needs the benzo, and then every 40 minutes, if this is a transfer, about every 40 minutes, he's probably going to need some more Norcuron. You go with when he starts to try to breathe, and it starts maybe try to move his arms or something, but typically you're looking for his diaphragmatic breathing, and then you know that he needs some more Norcuron. We're monitoring his vital signs, and making sure that we keep an eye on that. We're, especially if we've used sucks, we're keeping an eye out for malignant hypothermia and that refractory tachycardia and all that. If we didn't use sucks, ventilation and oxygenation issues, we may not have a choice, right? But we really don't want to ventilate him before we get him intubated if we can get away with it, simply because we don't want to put air in the belly that he's going to have a potential to throw back up. Right? Failure to sedate before paralyzing is a big one. Withholding sucks from a patient with a burn or a crush injury less than 6 to 8 hours old. You know, we probably, if we're using sucks, we don't want to use it in the burn patient after 6 to 8 hours, but it's okay to use it in that early time, right? And then failure to position the head properly. Again, if you're not using sucks, doesn't matter, right? Another clinician with equal airway skills is nice. We should be present. Should be does not mean must be, right? But we would like that, but it's not always feasible. Most of the time, it's not feasible. Now, sometimes in I'm thinking Warren County, but sometimes when you're running a 911 system, that you know, if you've got another truck available and nearby, a lot of times they'll just come in behind you and just to come to help, and that's a good thing about, you know, different trucks and different stations helping each other out. But we can't depend on that, right? That's not always the case, because like I said, you got 2 people out of town and 3 others are on calls, and you've only got 5 trucks on duty today. It's just you, right? And same thing here. I mean, you may very well have everybody at the station or everybody that could help, but then most of the time, you guys are spread out, all going different directions with different patients, right? So, something to think about. Backup system, we ought to have a backup system. Surgical airways are very good. It's my preferred backup, but you know, that's not always the case. The medical directors sometimes are reluctant to let us do surgical airway. It like RSI is a high dollar procedure, and it's the state requires initial, besides initial training, they require every 6 month renewal training for that. Right? Needle crack, I don't even consider that a backup. Right? A needle crack is, you know, where you put a 14 gauge needle in the trachea through the cricothyroid membrane. If you ever tried to ventilate with a bag valve mask, and a 3.0 endotracheal tube adapter will fit a 14 gauge needle, right? Have you ever tried to ventilate through that?
It sucks.
It ain't happening.
Yeah, it's hard to do. Really, the only thing you can do with a needle crack is give him some oxygen. You can't ventilate him because you can't get airflow. Now, if you've got a transtracheal device, a transtracheal jet insufflator that will shoot pressurized air in there, then that's a little easier to use. But most of us don't have those, so you know, just trying to use a BVM on a 3.0 tube adapter that's hooked to a 14 gauge needle is it's hard to do, right? And you can't ventilate him, so he's going to get hypercarbic. That 15 to 20 minutes of that, he's going to be hypercarbic. It'll be a big time respiratory acidosis, right? So there you go. I like the surgical airway. You know, most of us, not a lot of ambulance services allow that, so we're back to, are we going to use a combi tube? We're going to use a king? We're going to use an iGel, right? Are we going to use some type of a supraglottic airway that will allow us to ventilate this patient? And you hear people say, especially with sucks, well, if I can't get him intubated, I'm just going to bag him until he comes out from under it. Well, what have you done for him?
No.
You put him at great risk for no benefit. I mean, great risk and no benefit. So, something to think about. I got him paralyzed and sedated. I can't get him intubated. Help, come quick, come fast. Okay? So, if you can't place the intratracheal tube, then like we said, can you use an oral airway in a bag valve mask? Sure. What have you done for him? You've taken away his most basic instinct in the world, which is to take a breath, and you haven't replaced it with anything. Okay. Plus, you put him at risk for hyperkalemia, you put him at risk for malignant hypothermia, you put him at risk for all sorts of things, right? You put him at great risk for an anoxic brain injury, right? which those are really worse because he's still alive everywhere else, but the brain ain't working right. So you're now doomed him to a nursing home until he dies, right? So a double lumen airway or a needle or surgical crack. Okay. So we got a motor vehicle collision, single occupant. Right? He's unconscious. He's unresponsive. He's breathing 8 to 10 times a minute. He's breathing. Yeah, 8 times a minute. Right? He's got a GCS of 7. Well, we know GCS of 8. What? Intubate. So, does he have a gag reflex? Well, you can test for blink reflex, right? You can stick your finger in his mouth if you want to, once, right? You'll do it once. You won't do it much more than that.
Use your ink pen.
Do what?
Use your ink pen.
Yeah. Now, remember too that if you do it that once, you've also now created an obstructive airway, right? He's got a mechanical obstruction too. So, right? Do you want to attempt nasotracheal intubation? Well, I know we can take his face. I mean, you can check for stability of his zygoma and his mandible and his maxilla. But if you can take his face and move it in a complete circle, probably don't want to stick anything up his nose, right? Okay. What drugs are you going to need?
Pre-sedation.
I'm going to need some sedation, so probably Versed. I'm going to need ketamine. That's what we're using. I'm going to need some rocuronium or Norcuron, one of the two, rocuronium or Vecuronium, and then I'm going to need some more Versed, right, as we go down the road. Okay, cool. If he has a head injury, if he's bradycardic, if he has a head injury, maybe lidocaine if it's in your protocol, maybe not. If he's bradycardic, maybe some atropine. 0.5 milligrams of atropine might help him there too. We're probably not going to do a defasciculating neuromuscular blocker dose, and then a benzo probably for sedation. Okay, and we talked about ketamine for induction, maybe etomidate if we're not using ketamine, but then using some rock or Nor. Right? He has a gag reflex. He's now combative. Okay. So we also know he has seizures. What's that? What does that mean? Just think about it. If he's a known seizure patient, that's going to cut your neuromuscular blockers duration probably in about half, right? So he may very well, 10, 15 minutes later, he may be moving, right, after you give him a neuromuscular blocker if he's got a history of seizures. Okay, cool. So finally, we got intubation. Our tube is placed, the tube is secure. Heart rate increases by 20 to 40, approximately 5 minutes after the intubation. What's going on, what we need to do? Heart rate starts increasing. Our first response is give him some more benzo, right? Maybe he's waking up. So give him some more benzo, everything goes back to normal. Life is good, okay? That heart rate doesn't continue steadily moving up, and he doesn't start clenching. Doesn't become hard to ventilate, things like that. You notice that because you did take a baseline temperature, that his temperature now is still the same as his baseline temperature. Life is good, right? So here we go. We're staying away from malignant hypothermia, right? If we gave him sex, right? If we didn't give him sex, it's not really an issue because the non-depolarizings are not a trigger for malignant hypothermia, right? It's only the depolarizing one, which the only depolarizing we use is succinylcholine. Right? So we got to recognize this need. Lidocaine if it's in a protocol, atropine if it's in a protocol, or if it's appropriate. Then we'll sedate him and go through induction. We're probably not going to use succinylcholine. Probably not going to use etomidate right now. We're going to use ketamine, right? So we can use some ketamine, and then we're going to intubate him, confirm, secure, confirm, and then we're going to continue to paralyze him, continue to keep him sedated and chemically paralyzed with the Vecuronium or Rocuronium, and then what? Monitor him, and then we're going to what? Document. I'm of the opinion you can't document too much about an RSI. Some folks will just say, list what they did and list the drugs and not say anything else.
And then you get to the hospital and you get what? The airway confirmation signature.
Yeah.
For your
With ESO, ESO's got that built in, that airway confirmation signature, and you're getting signatures anyway. You know, is that tube in, doc? Yeah, okay. Will you sign that you're saying that the tube is in? Because I know it's in. I checked it. Every time I moved the patient, I checked him. Every time we hit a bump, a major bump, I checked it. I re-verified it. We get him out of the truck. I re-verified him at the back of the truck. We got him into the ER. Over on the ER stretcher, I re-verified it. I just want you to help me there and say, yes, we re-verified it and boom, the airway confirmation. If you intubate somebody, you as the bottom line to airway management in your environment, you have to know where that tube is at any given point in time. Right?
Please stay tuned for the next installment, introduction to ventilation, ventilators,